Today, we will be talking about the GI and the abdomen. Apologize for my computer being a little bit slow. So essentially, we're going to start a little bit further down from the GI tract. Obviously, it starts from the mouth, but we're going to be starting from the stomach. And I'm going to be taking you all the way through to the colon, and then towards the end, I'll try and summarize everything that we've been through. Throughout the entire lecture, there'll be some spotters as well along the way. There'll be lots of images as well for you to orientate yourself around the abdominal organs that we're going to discuss. So our learning objectives, obviously the first one is to leave with appropriate knowledge, but the second thing is to understand the relevance of the anatomy. Understanding this type of abdominal anatomy is incredibly crucial for a lot of diagnosis that you make as juniors and seniors as well. And it's also just to make anatomy a little bit fun, because if it was boring, then I'm not entirely sure how many of us would be able to get through it. The third point is to confidently and correctly also identify landmarks and spotters. And then the fourth point is just some consolidation tips for dissections and final exams from my side of things, and the things that really worked for me. Throughout the entire lecture, if you have any questions, please, I'm not sure how we can do this, but maybe they can message you, or they can make a point in the chat, and then you can pause me then and there, and I'm happy to answer the question then. And wait, we can talk about it at the end of the talk as well.
Yeah, sure. If you have any questions, just feel free to put it into the chat function, and we'll try our best to answer them at the end. Right.
So a little bit of an introduction to the gastrointestinal tract. So obviously it starts from the mouth in the oral cavity, and it goes all the way to the anus. It has various functions. Many are quite self-explanatory. So obviously in the mouth, you've got ingestion, towards the stomach and duodenum, you've got secretion. And then further down in the tracts, you've got the actual digestion, absorption, and obviously defecation right at the anus. The arterial supply is predominantly by the abdominal aorta. Venous drainage is to the inferior vena cava by the portal system, and the lymphatic drainage is into the thoracic duct. Just a bit of a disclaimer, I'm not going to be discussing the blood supply in a great amount of detail, but I have mentioned it in the slides where it's appropriate. Right, so the first thing we're going to start off with the stomach. So what is the stomach? So the stomach is a J-shaped bag. There are four anatomical regions of the stomach. So typically we have the cardia, we have the fundus, we have the body, and towards the exit of the stomach, we have the pylorus. Either sides of the stomach are known as margins. So towards you could say the left side, you have the lesser curvature, and on the right, or the bigger side towards the spleen, you've got the greater curvature. Most inferior part of the lesser curvature is known as the angular notch, and this is quite close to the esophagus. And the lesser curvature also gives rise to the hepatogastric ligament, which you understand as we talk about the liver further down also makes sense. There are two sphincters in the stomach as well. The function of these sphincters is to regulate the amount of food that enters the stomach. So the first sphincter that you have is in the inferior esophageal, or it's really at the level of T11, and it's the inferior esophageal sphincter. So this is regulating the amount of food that we can swallow. A clinical correlation for this might be sometimes, regardless of age, usually happens in younger kids, but sometimes you can have achalasia, and that gives you a bit of a very strong tone of the sphincter, and the way you correct it is by obviously doing a myotomy. You have the second sphincter, which is the pyloric sphincter, which is controlling the exit of the digested mixture from the stomach. And this is made of smooth muscle entirely, whereas inferior esophageal sphincter is not. In terms of the arterial supply, so it's coming from the celiac trunk. The celiac trunk is, you could say, the most northern trunks that you need to know for the GI tract. You've obviously got the others. You've got the superior mesenteric artery trunk, and you've got the inferior mesenteric artery trunk. And celiac is the most superior most. Venous supply, you've got the right and the right and the left gastric veins, which are then draining into the hepatic portal vein. Nerve supply, it's from the autonomic nervous system, whereas the parasympathetic is coming from the vagus, and then the sympathetic is via the celiac plexus, which receives supply from the T6 to T9 segments as well. So this is an image of the stomach now coming up. So I don't know if can you see my my mouse, or can everyone see? So I think you guys can see. Maybe if you can't, let me know in the chat. But this is obviously a lesser curvature. So this is the left part of the margin, or the left margin, and this is our big great curvature on the right side of the margin. You've got four parts, as I said. So you've got the cardiac, fundus, the body, and then the pylorus. So this is the exit of the stomach, essentially. You've got a sphincter here. This is one of the regulatory sphincters. The other one is around about here, at the level of T11. And yeah, so this is all smooth muscle here. So you've got the circular muscle layer, which is the internalmost layer, and then you've got the longitudinal muscle layer as well. And then internally, as you can see here, you've also got rugae. Sometimes in, or for some of you might have seen esophagastro OGDs, esophagastroduodenoscopies, and sometimes in those you can see that there's some ulcerations in the rugae here, which is a sign of peptic ulcer disease. All right, so the first spot of the day. This is quite easy, but I'm going to try and catch you guys out a little bit somewhere. So can everyone please tell me, or can everyone write in the chat box what you think this landmark is here on the left side? Should be quite easy. Yeah, exactly. So obviously this is the liver. And the second landmark, what does everyone think that is? So the second landmark is obviously the stomach. But other landmarks here which aren't really labeled, which you can't see very well. This is the, can anyone tell me what this is before I tell everyone? So this is the, no, it's unfortunately it's not the gallbladder. This is the falciform ligament here from the liver. The gallbladder is a little bit more posterior. This is up the gallbladder here. Exactly. Can anyone please tell me what this landmark here is? In the right, so the left upper quadrant. Yeah, exactly. So that's our spleen. So I think the easiest way in spotters to identify where things are, I know it's relatively simple to the naked eye, but sometimes it can be a bit messy depending on your cadaver. But the way that I usually try and identify things is by trying to find the spleen first. And then I know that from the spleen, if I keep tracking medially, I'm going to reach the stomach. And the stomach will obviously be an extension of the esophagus, which will obviously be protruding through the diaphragm as well. So that's a really good way of just double checking that you're in the stomach and not anywhere else. Right, so as everyone correctly answered, that is the liver and the stomach. Moving on, now to the small intestine. What is the small intestine? So the small intestine is made up of a few more parts rather than just plain up small intestine. So the duodenum is the first part of the small intestine, and it is C-shaped. It's around about 25 centimeters long, and it wraps around the head of the pancreas. There are 4 different parts of the duodenum, and we're going to talk about those parts now and their relation to other abdominal organs. So in the superior part of the duodenum, which is at the level of L1, it's coming directly from the pylorus, and the superior part of the duodenum is actually connected to the liver by the hepatoduodenal ligament. In the next slides, you'll be able to test or to see these ligaments that I'm talking about in this slide now. But after the superior part, you have the descending part. So this is the second part. This is from the level of L1 to L3, and it curves inferiorly around the head of the pancreas. It's posterior to the transverse colon, but it's anterior to the right kidney and also Vater's papilla, which will be the point where the bile and pancreatic juices are entering the duodenum, obviously, to emulsify and break down all the food that you've just eaten, and to give it color, obviously, as well. The third part is the inferior part. This is between L2 and L3, and it travels laterally to the left of the abdomen, crossing the inferior vena cava and the aorta, and it remains posterior to this superior mesenteric artery. The fourth and final part is the ascending duodenum. This starts off towards the L3 level and is actually going up to about L2, which is why you've noticed I've written it in a funny way rather than writing it in sensical way, which would be L2 to L3. And after the ascending duodenum crosses the aorta, it ascends and it curves anteriorly, as I just described, to join the jejunum at a turn called the duodenojejunal flexure. And at this flexure, you have the suspensory muscle and the ligament of the duodenum. Now, this muscle is quite important because essentially what it does is it regulates the movement of stomach contents into the jejunum. Sorry. So you have contraction of this muscle, which is widening the angle of the flexure, and it's causing peristaltic or positive peristaltic movement towards the first part of the big small intestine, the jejunum and the ileum. So this is an image of what the duodenum looks like. So this is obviously the pylorus. This is the superior part. So this is D1, you could say. Then you have the inferior part. So inferior part will be D2. This is D3. Sorry, this is the descending part. D3 is the inferior aspect, just after the Vater's duodenal papilla. And then you have D4, which is the superior part. And this is the duodenojejunal flexure, which contains the duodenal ligament, which is contracting and relaxing to allow food from the stomach to either enter the jejunum or to hold fire, essentially. Right, so that's the duodenum done. Then you get to the messy loops of bowel, which are quite difficult for pretty much anyone to confidently tell you whether they're jejunum or they're ileum. But if you understand the basics I'm going to talk about in the next few slides, this should be quite easy to you. So obviously you have you obviously have the ileocecal valve. So I guess you could work your way from the large colon all the way back up. But the only way to actually truly differentiate between the jejunum and the ileum, you can only do it by histology. And in contrast to the duodenum, The small intestines, the jejunum and the ileum, are actually intraperitoneal, and they are attached to the posterior abdominal wall by the mesentery. And I'm going to be discussing the mesentery later on in the slides. But for you to get an idea of how long it is, or dimensions of the small intestine. So in total, you have 6 meters or 20 foot, or 20 foot of small bowel, essentially. So you've got 8 foot of the jejunum and 12 foot of the ileum. The jejunum, as I've said, starts at the DJ flexure. And yep, I'm just repeating myself here, but there's no clear demarcation point between the jejunum and the ileum. You can really only do it by histology. Ileum terminates at the ileocecal valve. And at this point, the ileum invaginates into the cecum. And an important point here to understand and mention here is that it cannot actually propagate food contents forward, but it can only prevent reflux. And this is quite important when it comes to things like obstructions further down the line. And it also means that obstructions in the large colon are quite easily identifiable. So what are the differences? On the left, you've got the jejunum, which is the first, or what comes before the ileum. So the way to differentiate between the two types, you have the vasorector. In the jejunum, the vasorector will be really, really long, and you'll have fewer arcades here. These arcades are coming directly from the mesentery, and in the ileum, you have more rows of arterial arcades, but you have shorter vasorector. In terms of the histological picture, you also have a thicker wall in the jejunum, whereas you have a thin wall in the ileum. In the jejunum, your circular folds, which are helping with the contraction, they're much larger and they're actually closely set. So this will allow for a stronger contraction. And sometimes you can also have solitary nodes, more for lymphatic purposes. Whereas in the ileum, you have Peyer's patches, once again for lymphatic purposes, and the circular folds are shorter and much sparse. Interestingly, out of curiosity, you only actually need 2/5 of small bowel to work, to maintain physiological competence of the body. Right, so this is a little bit more difficult, but I think this should also be quite easy to all of you who've been listening. So can you all please tell me, we'll work through it one by one. What do you think this landmark is here, the first one on the left, just above duodenum? Or rather, yeah, I think everyone's going to answer it well. Rather, why don't you guys write out all of your answers to all of the landmarks, and then we'll discuss it in the next slide. So let's work our way from the left to the right, if you wouldn't mind. But yeah, for those of you answering, the leftmost is actually D1, so it's the superior duodenum. I'll give you guys 30 seconds or up to a minute, and then we'll move on to the answers. Right, so can everyone share their answers, please? If not, don't worry, I'm going to be telling you exactly what everything is. So the answers are, as you can see. So the first or the leftmost landmark is the first part of the duodenum, so it's D1, very easy. The next part is obviously D2, D3, D4, and then you've got the jejunum. Can anyone tell me what the landmark is that I'm hovering my mouse over in the chat box? Is the duodenal, or it's the duodenal ligament, so the DJ flexure. And can anyone also tell me what this artery here is? I'm just running along with my mouse. Can anyone tell me what this artery is? Exactly. And how do you know it's the splenic artery?
Is that the splenic artery?
Yeah, so it's the splenic artery, but how do we know if the spleen wasn't there, how would we know that that's the splenic artery?
I think it's defined as tortuous.
Yeah, exactly. So it's tortuous, but there's another landmark that we can trace to know that it's the splenic artery. Does anyone know what it is? We're not really discussing it in this lecture, but I think it's worthwhile mentioning it. So the way that we find, yeah, exactly. Well, it's actually not above the pancreas, just in this cadaver, because the pancreas is really atrophic, because obviously this is a cadaver. But in general, the splenic artery runs along the posterior margin of the spleen, of the pancreas, rather, and there's actually an impression for the splenic artery to travel through. Obviously, it's tortuous, but that's how we find out, or that's how we confirm that we are actually at the splenic artery. Does that make sense? Let's move on. So we've done one spot. Oh, we've done two spotters now. Let's move on to this one. So I'm going to give you guys 30 seconds once again. If you can work your way from the left to the right and in anti-clockwise manner, that would be great. And I will share the answers in the next page in 30 seconds. Might be a little bit harder, but I think you guys should be able to figure it out. Right, so you have the ileum on the left side, and you've got the mesentery, which is the twofold membrane, which I'm going to be discussing later on. But the mesentery is obviously encapsulating all of the ileum and the jejunum, and it's providing pretty much every single function that both of those organs need. You've got the jejunum here. Jejunum, how can you figure this out? Well, I would be able to figure this out from this image, because the jejunum is obviously starting from the DJ flexure. The DJ flexure is most of the time on the left upper quadrant, and this seems to be coming from the left upper quadrant. So this is likely jejunum. This is ileum de facto. You've got the mesentery here, and you've got the root of the mesentery. And yeah, so this is this. Onto the liver now. Once again, so what are the functions of the liver? So the liver is producing bile, and it has lots of metabolic functions. You don't need to go into all of the metabolic functions. It's the biggest gland in the body. It weighs roughly 1.5 kilos, and it's located in the right upper quadrant. In terms of the relations of it, I'm sorry, I've shortened the right lobe to RL and the left lobe to LL. But posteriorly to the right lobe, you have the right kidney, and that gives the posterior aspect of the liver the renal impression. You also have the right suprarenal gland, because obviously that sits above the kidney. You have the descending part of the duodenum. So the descending part of the duodenum is D2, which is giving the duodenal impression. You have the right colic impression, or rather you've got the colic impression from the right colic flexure. And on the left lobe, you have the esophageal impression and the gastric impression, because it sits very nicely on top of those. It's also made up of quite a thick fibrous capsule, and within those fibrous capsules, you've got hepatic lobules, which are the actual functional, well, they're not really the functional units, but everyone thinks that they're the functional units, and they're encapsulated with a small central vein, which is a branch of one of the hepatic, or the big hepatic vein. And the functional unit is actually the portal acinus on a histological scale, but everyone always says hepatocytes, which is sort of right, but it's not really right. Blood flow, you have the portal vein, which is supplying it's draining the venous system, and the arterial blood supply is coming from the proper hepatic artery. Can someone please tell me in the chat box where the proper hepatic artery is coming from? If not, don't worry, I'll answer it. So the proper hepatic artery is a branch of the celiac trunk. So this is your bog standard liver picture. Right lobe here, left lobe here, gallbladder just sticking out. This is the falciform ligament, which I asked you guys about in one of the earlier slides. You've got the bare area here, or the naked area here, on the right lobe aspect, and on the right lobe you've got all of the renal impression. You've got this mesh inferior aspect. This is the colic impression from the right colic flexure. This is the gallbladder. You've got the gallbladder fossa here as well, between or behind that, and yeah, you have the posterior aspect of the falciform ligament coming through here. You've got a caudate lobe, and then you've got the proper hepatic artery, the portal vein, and the hepatic duct as well. Right, so you've got many different surfaces of the liver. So you have the diaphragmatic surface, which is superior aspect, which is fusing with the diaphragm. It's a bare area, and the bare area defines the coronary ligament that continues to the right triangular and the left triangular ligaments, and it terminates as the fibrous appendix, which you can't see very well, but usually the fibrous appendix is just sticking out here. The anterior part of the diaphragmatic surface is covered by peritoneum. We're going to talk about which type of peritoneum it is in a few slides, and it is divided by the falciform ligament into the right and the left lobe. So this is a very important landmark for us discovering what's the right, what's the left, really. The visceral surface is in the shape of a H. So I think it's quite easy here. It's a nice H on this aspect here on the posterior margin. And you have the right sagittal fissure, which once again you can't see, apologies for that, but it is posteriorly the groove of the inferior vena cava. It's fixed by a fibrous band, which is the vena caval ligament. Anteriorly is the gallbladder fossa, whereas on the left sagittal fissure you have the posteriorly venous ligament, or sorry, posteriorly you've got the venous ligament, which is the occluded venous duct. It's a remnant of it rather. And anteriorly you've got the round ligament of the liver, which is the remnant of the occluded umbilical vein. I'm not going to test you on what time frames those things shut, but something that you guys need to know. And obviously you've got segments. So can someone tell me how many segments we have in the liver? In the chat box, please. Give you guys a few seconds. Last few seconds. You have 8 segments. And a nice way of remembering 8 segments is in the shape of a fist. I unfortunately don't have enough time to teach you how that works, but if you look at this image here, you'll be able to identify how you could potentially associate the fist in the 8 segments. You might be wondering, where's the first segment? The first segment is on the visceral surface, usually around about the caudate lobe region. So this is the diaphragmatic surface, the superior aspect of it. So as we've discussed, this is the bare area here. So you would be roughly in this area here, the bare area. You've got the anterior fold of the coronary ligament. The coronary ligament is running through here from the right triangular ligament and then the left triangular ligament. You've got the falciform ligament, which is going all the way from the front to the back. And on this image here, which is the visceral surface, you can clearly see the fissures. I'm really sorry for the quality of this image. I don't think it's very clear. But you have the right sagittal fissure, which is on the right aspect of the liver lobe. And then you've got the left or the umbilical sagittal fissure here, which is a remnant of the umbilical vein. So a spotter for you guys. Can we work in clockwise fashion from the top all the way to this part here, which is at 7 o'clock, please? Can everyone send in their answers all at once? I'll give you guys 30 seconds. That's okay. Right, so can everyone please send in their answers if they tried? Right, so moving on to the next slide. Right, so yeah, yeah, I think a lot of you have probably got this locked down really well. So the first one is obviously the porta hepatis. So this is the entire vasculature of the liver. On this aspect, the most superior aspect, you've got the vein, so hepatic portal vein. On the right lobe of the liver, the furthermost one that I like to associate this is usually the branch of the right hepatic artery proper. Here, or the most inferior aspect of it, you have the common hepatic duct, and furthest from the left, you've got the left branch of the hepatic artery proper, which will then be splitting into all of the individual units, which will be supplying the portal acinus. Really good. Next one, I'll give you guys 30 seconds again, and we'll go through the answers. Yeah, let's go through the answers. So I'm just checking through some of these answers. Yeah, I think everyone who's answered is right. I'm glad to know you've been paying attention. So this is obviously our liver. This is the falciform ligament, which is going all the way from the anterior aspect all the way to the posterior aspect. This is the hepatoduodenal ligament. How do you know it's the duodenum? Well, this is directly coming from the stomach. This is your stomach here. So you have the superior part, and the superior part is attached to the liver. And this is the landmark for the lesser omentum. This is the duodenum. Why? Well, it's coming from the stomach. So that's how we know that's the duodenum. That's good. Next one. Let's give you a few seconds for this one. Just type it out or shout it out. Right, so what do you guys think? Let's move on to the answer page. You can send in your answers. Exactly. I think you guys have got it quite well. Just going back, can anyone please tell me what this line is here? Can't see it very well, but what do you think this is? Describing in the most vaguest of ways, because I don't want to give it away too easily, but if someone could tell me what this is here, that'd be great. This is the right sagittal fissure, and then this is your left sagittal fissure. This is the left lobe, obviously it's the right lobe. Fissure here, and the visceral surface is in a very H-type pattern here. Moving on to the last plotter, I think, for a while. So this is just combining everything that we've talked through. Hopefully you guys can get this. Can we try and answer this in a clockwise manner? So starting from the top left corner all the way to 3 o'clock. Give you guys 30 seconds once again. Right, so the answers for this are, so starting from the top left, so this is our cystic duct. So this is the duct coming from the gallbladder and going all the way to form the common bile duct. You have the right hepatic duct. This is coming from the right lobe. You have the left hepatic duct, which is coming from the left lobe. You've got this, you've got the common hepatic duct, which is obviously the common duct from both of these two ducts, and then you've got the bile duct or the common bile duct, and that's going all the way inferiorly until it reaches the pancreas, where the pancreas is obviously also producing a bit of enzymes and other things as well, and that's going to transfer them all the way to the descending part of the duodenum via the pancreatic duct, and then they will be excreted or expelled through the vatus papilla, which I don't think you can see very clearly, but you could probably identify somewhere around here. So yeah, good. Once again, I think everyone is listening, which is good. So you have the peritoneum. So the peritoneum is a thin serous membrane which consists of a single layer of flattened cells. These flattened cells are known as mesothelium. And in terms of the peritoneum, we have two types of peritoneum, or we can differentiate peritoneum into two different components. So you have the parietal peritoneum, which is lining the walls of the abdominal and the pelvic cavities. And then you have the visceral peritoneum, which is covering the internal organs. And you also have the greater sac, which is the main component, as you can see in this image here, of the peritoneal cavity, whereas the lesser sac is the small diverticulum from the greater sac, which it communicates via the epiploic foramen of Winslow rather, and that is lying behind the stomach, and it is called the omental bursa sometimes. So just remember everything on this page. I'm going to describe everything very basically in the next one. So on this image here, you have a sagittal section of the abdomen. So you obviously have the liver here. You have the parietal peritoneum. Once again, I'm very sorry for the resolution of this image. I don't think it's very clear. So you have the parietal peritoneum, which is covering the entire abdominal cavity and the pelvic cavity as well here. And you've got the visceral peritoneum, which is actually communicating with internal organs such as the liver here. You have the stomach and also the small bowel. Small bowel here is attached to a big mesentery here, and this is the root of the mesentery, which you can see right here. The duodenum is obviously in the retroperitoneum, so it will not be included in the peritoneal cavity. This cavity is also filled with fluid. It's not the same as ascites. And once again, it's something to remember when it comes to your spotters. And here you have a transverse section. So once again, anything retroperitoneal will not be covered by any peritoneum. Whereas the visceral peritoneum is covering all organs here, and the parietal peritoneum is covering the entire cavity. This is our mesentery once again, which contains all of the blood supply and all of the lymphatics as well, and also some muscles as well for the small bowel. So I'm going to talk to you a little bit about the epiploic foramen, but for you to understand what the epiploic foramen of Winslow is, I think it's important to just visualize where it is and how you reach it. So obviously you have the gallbladder here. You have the liver, which is very large. You obviously can't miss that. Just inferior to it, you have the duodenal, or rather the hepatic duodenal ligament, and just in the inferior margin of the hepatoduodenal ligament, you have a small little orifice here, and this is the opening from the greater omentum into the lesser omentum, and the omental bursa is just behind the lesser omentum, which will be accessed through this foramen here, the epiploic foramen. Right, so what are the boundaries of the epiploic foramen? So you're looking at it now as if this is a rather a sagittal image. So just imagine that this is a sagittal image of the abdomen, anteriorly here, posteriorly here, superior and inferior margins. So anteriorly, you have the free margin of the lesser omentum, which is containing the porta hepatis. You've got the hepatic artery, you have the bile duct, you've got the portal vein. Superiorly, we've got the caudate lobe of the liver. Inferiorly, we have the first part of the duodenum, which will be D1, obviously, and it's the superior part of the duodenum. Something that's not missing, or it's missing here, is you've got the hepatoduodenal ligament here as well. And then posteriorly, you've got the inferior vena cava. And now would be a good time to also mention, okay, no worries, thank you. Now would be a good time to mention that you have other terms as well that I've mentioned, but I'm not really described very well till now. So you have the mesentery, the omentum, and then you've got paracolic gutters as well, which are all synonymous with peritoneum. So the mesentery is two layered folds of the peritoneum, which are attaching to the intestines, and they're attaching the intestines to the posterior abdominal wall. The viscus of the mesentery is suspended by, and it's enclosing the peritoneum, and this mesentery will contain fat, blood vessels, and lymphatics as well, which will be incredibly important for the function of the small bowel. Then you obviously have the omentum, which I don't think you can see. You've got the omentum, which you can kind of see here. We'll say this is the omentum here, right here, the yellowy fatty bit, and that is once again a two-layered fold of peritoneum, which is attaching the stomach to all the other viscous organs in that region. You have paracolic gutters. I don't think you can see them in any of these images, sorry. But the paracolic gutters, just a quick word on them. They basically lie on the lateral and the medial side of the ascending and the descending. So this would be the descending, and this would be the ascending colon. They're also basically gutters where fluid can accumulate, and they're also in the subphrenic space as well. Right, moving on. Another spotter. Can you guys please tell me what these landmarks are from in an anti-clockwise way, please? So from the left to the right. I'll give you 30 seconds. Last few seconds before I tell you the answers. Right, let's go through the answers. So if everyone could release the answers into the chat, please. Right, so the answers are from in anti-clockwise manner. You have the external oblique here, which is the outermost muscle. You have the internal oblique here. You have the transverse abdominis. And then just underneath the transverse abdominis, you have the parietal peritoneum, and you've got a little bit of fat here, which you can just about make out. But before you get to all of this layer, you have the fascia, and the fascia will be the last. It'll be the last little bit of muscle or soft tissue before you get to the peritoneum. It's very, very fine. You can never usually see this in practice, but on cadavers, it is easily seen. Can anyone tell me which part of the abdomen this is? Just take a guess if you have to. Epigastric region, good guess. Lumbar, not bad. Yeah, so this is the hypergastric region actually. As you guys know, you have the hands in pockets mnemonic, or however you guys want to describe it. So you have the hands in pockets, and that kind of tells you that this is in the hypergastric / iliac fossa type regions as well, with the external oblique, internal oblique, and the transverse abdominis. Obviously no rectus here and no linea alba, so you know you're a bit more lateral rather than medial. Yeah, let's move on to the last section, which will be the colon. So the colon is 150 centimeters in length. It's not as big as the small bowel, but once again, it's quite sizable. And from the proximal aspect to the distal aspect, you have the ascending, transverse, descending, and the sigmoid colon. The ascending colon is retroperitoneal, and it meets the right lobe of the liver at the not the hepatic flexure, rather, at the colic impression, and it turns 90 degrees to move horizontally. And at this point, we would know this as the right colic flexure or the hepatic flexure. And this is the start of the transverse colon. The transverse colon is extending to the spleen, where it turns another 90 degrees to point inferiorly downwards. And at this point, we know this as the splenic flexure. At this landmark, you have a bit of colon which is attached to the diaphragm, and the ligament that we know this attachment as is known as the phrenico-colic ligament. It is the least fixed part of the colon. So if it's the least fixed part of the colon, you can understand how difficult it is to try to get bowel to stay up in the upper quadrants, for example, during some surgical procedures. It's because of the phrenico-colic ligament. Another word on the transverse colon is intraperitoneal, and it is enclosed by transverse mesocolon. The descending colon is moving inferiorly all the way down to the pelvis. It remains retroperitoneal throughout, and it is anterior to the left kidney. And when it turns medially, at this point, we know it as the sigmoid colon. So the sigmoid colon is 40 centimeters in length and is in the left, or it's essentially in the lower inguinal quadrant, and it is a S shape, which is quite important to understand and to familiarize yourself, because S, sigmoid, that's how I like to remember it. And it is extending from the left iliac fossa all the way to the sacrum, especially S3. It's attached to the posterior pelvic wall by a mesentery known as the sigmoid mesocolon. So throughout the lecture, I've mentioned lots of things which have hopefully been useful, but can anyone in the chat box please remind me the connections of the mesentery to, or rather not the mesentery, the peritoneum to internal organs, or the ones that you've heard in this talk. Can you please let me know in the chat box, so I know that you guys are understanding what I'm talking about. A lot of them are on this page, actually. So you have the mesentery. So the mesentery is going to be supplying the small bowel. Then you have the transverse mesocolon for the transverse colon. And then you've got the sigmoid mesocolon straight after the inferior colon, or the descending colon. Not mention the blood supply, but now would be a good point to arise the blood supply from. So you've got two big trunks which are supplying the large bowel. So you've got the superior mesenteric artery here. Anyone tell me what level this is roughly? Yeah, exactly. It's L1. Well, L1, L2. A bit difficult to be specific sometimes. And the inferior mesenteric artery is coming from L2 to L3. So the superior mesenteric artery is giving off a couple of branches. So you have the middle colic artery here. And then the middle colic artery will then turn into the right colic here. And the right colic will be supplying the entire right side of the bowel. We'll have the appendicular artery, which will be supplied once again to the superior mesenteric artery. And one of the branches from the iliac arteries and the jejunal arteries can also sometimes form contributaries, which will be providing the blood supply for the appendix. You've got the ileocolic arteries as well. This will anastomose in such a way that if one of these branches is compromised, the area will still have blood because of this anastomose. Can someone tell me what the anastomosis is called? So the anastomosis is called Haler's anastomosis. You might have come across that word. It's usually not in any of these pictures. I don't know why. But that's quite important because it provides the entire bowel with collateral blood supply. This is Cannon's Point. This is known as the watershed area. This is usually where, if there are cancers, they're usually in this area. Don't need to go into that in this lecture, but just something for you guys, which is interesting. And the inferior mesenteric artery is giving off the left colic artery, the sigmoid arteries, and the superior rectal artery. Nothing more, nothing less. So the left colic, the sigmoid, and the superior rectal artery. You might be asking, where does the inferior rectal artery come from, or where does the middle rectal artery come from? And that is not relevant, because those will be coming from the iliacs. And also you should know that there is no middle rectal artery. There's only a middle rectal vein. Moving on. So this is the theory that we discussed in the first slide. So you have the cecum here, and from the cecum you've got the first part of the colon. So you've got the ascending colon, you have the transverse colon, the descending colon, and then you've got the sigmoid colon here in typical S shape. And the sigmoid colon will then continue to the rectum, and then the anal canal, where all of the things that we've eaten are excreted through. This is, or the transverse colon is part of mesocolon. So that's why you can see this attachment here from the peritoneum. And the sigmoid will also be attached in mesosigmoid way to the peritoneum as well. This is the variform appendix, or just the appendix. Right, so a bit of another bit of spotting. Can you guys work through this? This will be our last spotter, I think. Can you please work all the way from the top to the bottom? I'll give you guys 30 seconds. Right, so can you guys please send in your answers to the chat box? So from the top to the bottom, we have the marginal artery. Also, you could call it the common colon or the common colonic artery, or Ehlers anastomosis, or marginal artery, however you want to say it, which will be the branch, which will be the collateral for the entire bit of bowel. You've got the middle colic artery here. You've got the right colic artery, which is just inferior to it. You have the ileocolic arteries. And you can't see them very clearly here, but you should have some jejunal and some ileal arteries. Before you get to the appendicular artery, which is obviously giving the blood supply to the appendix. Does that make sense? Can you all let me know in the chat box, please? And if you'd like me to return to some of the slides, I'm happy to do that, or explain anything that you've not understood as well. I'm happy to do that right now. Before we move on. I'll take that as no questions. Oh, yeah. Okay. The marginal artery. Fine. So the marginal artery is, once again, or the marginal artery of Drummond, however you want to say it, is a blood vessel which forms a major network between the superior and the inferior mesenteric arteries. It is a collateral blood supply. So that means that if you shut off the blood supply in the superior mesenteric artery, the inferior mesenteric artery would provide blood all the way through it, through this artery, in order to not cause any bowel to become atrophic due to the anastomosis. So it's sometimes known as the marginal artery of Drummond, or Ehlers anastomosis, or the marginal artery. It doesn't really matter how you want to describe it, but it's a major anastomotic network. Does that make sense? And I think from when I remember studying anatomy as well, I think it was it is variable. Sometimes people have the marginal artery, sometimes people have no marginal arteries, but in general, I think there will always be a collateral blood supply to the entire large colon. What is the big darkish structure left to the appendicular artery? That is a good question. So that is a very disgusting part of ascending colon. So you've got the appendicular artery here. You should have the appendix somewhere here. You have the ileocecal valve here, and this is the large colon. This will be the ascending colon. Hope I've answered your question, Sola. Right, let's move on. So moving on to the rectum and the anal canal. The rectum is a temporary storage for feces. It's proximal to the sigmoid colon and it will terminate into the anal canal. Begins at S3 and macroscopically it's very different from the colon. And the final segment is the ampulla. Sometimes we know this as the rectal ampulla, and it is continuous with the anal canal. The course of the rectum is marked by two major flexures, which we'll see in the next slide. And they are the sacral flexure, which is an anterior-posterior curve with concavity anteriorly. And then you've got the anorectal flexure, which is once again an anterior-posterior curve with convexity anteriorly. And the anorectal flexure is formed by the tone of the puborectalis muscle. The superior and 1/3 anterior and lateral surfaces are covered by the peritoneum. The middle third has only anterior covering, so the posterior aspect is completely not attached to any side of peritoneum, and the lower third has none. Reflections of the peritoneum from the rectum to the posterior valves can form pouches, which you'll see in the next slide as well. In terms of arterial supply, so you've got the superior rectal, the middle rectal, and the inferior rectal. I also understand I made a mistake. There is in fact a middle rectal artery. I apologize for that. In terms of the venous supply, you've got corresponding veins as like the arteries, and they will be draining into the portocable anastomosis. Nervous supply, sympathetic, is coming from the lumbar splanchnic nerves and the superior and inferior hypogastric plexus, whereas the parasympathetic is coming from the pelvic splanchnic nerves and the inferior hypogastric plexus. And you also have visceral afferent sensory fibers, which will be following the parasympathetic supply and will be responsible for the parasympathetic functions. So this is the rectum. This is obviously the sigmoid. Sorry about the Spanish. Sigmoid here, you've got the rectum. This bit here is the rectal ampulla before you get to the anal canal. And these are the rectum relations. So the peritoneal reflections of the rectum that I wanted to talk about were the recto-uterine pouch. So the rectum here, the uterus here, got the recto-uterine pouch here, and you have the vesico-uterine pouch, which will be between the bladder and the uterus. And then you also have the recto-vesical pouch in males. Can anyone tell me what the recto-uterine pouch is called, usually? Exactly, you've got the pouch of Douglas. Can anyone tell me what the pouch of Douglas is important for, apart from this? So any infection in any of these regions, especially the gynae region, will have a bit of free fluid, and the free fluid is always, well, not always, but most of the time, it is found in the pouch of Douglas. And if you're doing an ultrasound scan or a CT scan, if you see some fluid in the pouch of Douglas, you might think it to be a bit suspicious for an infection in the region. So that is the clinical relevance of the pouch of Douglas. There's no pouch of Douglas in males, unfortunately. Right, so the final segment, we're anal canal now, or on the anal canal rather, and it plays an important role in defecation and maintaining fecal continence due to sphincters. It begins as a continuation of the rectum, and it passes inferior-posteriorly to terminate at the anus. As I mentioned, it has two sphincters. So you've got the internal sphincter, which is surrounding the upper 2/3 of the anal canal, and it's formed by thickening of the involuntary circular smooth muscle, which is also in the bowel wall. You've got the external sphincter, which is a voluntary muscle that surrounds the lower third of the canal, and it overlaps with the internal sphincter, and it blends superiorly with the puborectalis muscle of the pelvic floor. At the junction of the rectum and the anal canal, there's a muscular ring, and this is known as the anorectal ring. This is usually felt on the DRE, and it is a fusion basically of the internal, external, and the internal, external sphincters and the puborectalis muscle. So that's the muscular ring which you feel during a digital rectal exam. The columns are joined together at the inferior ends by the anal valves. Above the valves, you have small pouches known as anal sinuses. These will be secreting the mucus. So sometimes if people have large bits of bowels removed and they have a stoma bag and they're still producing things from the back passage, it's because the anal sinuses are still there. They're obviously working and they're secreting mucus. The valves collectively form an irregular circle known as the pectinate line or the dentate line, and this divides the anal canal into the upper and the lower part, and the upper and the lower parts have various blood supply. So for example, the upper part will be supplied by the middle rectal artery, whereas the inferior part will be through the inferior rectal artery, and the embryological origin is also very different as well. So this is the anal canal. This is your dentate line or pectinate line, however you want to describe it. You have the rectum here. You have the rectal ampulla right there, and you've got the continuation to the anus, obviously. You can see, or you can't see very clearly, but you can see that this is the external sphincter muscle here, and then you have the internal sphincter, and the external sphincter is fusing or binding onto the internal sphincter as well. I think this provides a bit more reinforcement and more stronger muscle contraction, especially in terms of fecal incontinence. And then you have, can't see very clearly here, but you've got a few anal sinuses which will be producing the mucus, and you've got the anal verge here and the anoderm, which is embryologically a remnant of the hindgut, obviously.